Sleep disorders can be quite commonly manifested in the geriatric age group. So we are basically going through the causative factors that are leading towards these sleep disorders in this age group. So sometimes we have to basically distinguish these sleep disorders from normal physiological pattern changes or the normal circadian rhythm changes that are observed in this age group from the pathological changes or some of the changes that can basically be affecting the lifestyle of these individuals. The performances, the mood disorders can be seen, the affective disorders can be seen, even it can lead to a depressive episode in the individuals who are suffering from sleep disorders at this older age group. So what are the criteria that we have to go through? How are we going to assess these patients? History taking is one of the important factors over here. The documentation, taking the past medical, the surgical history, and taking the childhood history, it's again very important. The life circumstances has to be known by the clinical psychiatrist just to know the causative factors of that individual, and only then one can devise methods to basically counteract these sleep disorders in these individuals. So basically, the evaluation is done quite in a detailed way, just to know, just to take out the factors that are basically causing the sleep disorders in these individuals. And then the medical history is taken in detail as well, just to know the comorbids that are present in these individuals and that can also manifest as sleep disorders in these individuals. And then we have the non-pharmacological interventions discussed. There are a lot of pharmacological interventions as well. One should know about them as well, but the non-pharmacological interventions basically ranging from the cognitive behavioral therapies, the counseling sessions, knowing the sleep hygiene, all of these treatments and the treatment modalities are basically devised to control the sleep disorders in these individuals. So basically, the evaluation of the patient is again very important. We have to take a detailed medical history over here, which includes the social history and the late life stresses that we've already focused on, having the comorbidities, having the stresses of life, the emptiness syndrome. All of these are the late life stresses that can basically perpetuate these sleep disorders in these individuals. Then we have the ETOH, or the caffeine use, which can be one of the causative factors. Then we have the medication review. The drug interactions can cause insomnias in a lot of individuals. So one should know what are the comorbid conditions that are present in that particular patient, and one should know the medications or the prescriptions that he is on. So the psychiatric history or the past psychiatric history is again very important. It can be any anxiety disorder manifesting as sleep disorder. It can be any obsessive-compulsive disorder manifesting as sleep disorder in the older age group people over here. So it can be depression, mania, and psychosis as well. The sleep history, while you're taking the sleep history from the individual, one should know what time you go to bed and what is the wake-up time. So you know the normal circadian rhythm, and you have to basically compare these two circadian rhythms and the normal circadian rhythm of the individual as well. The timings of insomnias are noted down. The sleep schedule is noted down. And then you know about the sleep environment. Is it something in the environment that is causing that insomnia in the individual? Sleep habits. Then we have the daytime effects of the sleep. And then lastly, we're going to ask about the symptoms of the other sleep disorders as well. So this is the complete sleep history that you're taking whenever you're categorizing a patient with suffering from a sleep disorder. You're going to know all of these points in detail. The past medical history is again very important over here. The common conditions associated with sleep disturbances are the comorbidities basically that are associated are arthritis. Then we have the congestive heart failure. We have the gastrointestinal disorders, the asthmatic conditions, angina, arrhythmias, the urinary incontinence or the urinary symptoms. It can be even the urinary tract infections that can lead to the sleep disorders. Then we have, on the other hand, we have the neurological symptoms that can also manifest as sleep disorders in these individuals. So the non-pharmacological managements are the sleep hygiene, the stimulus control in these individuals. Then we have the sleep restrictions that are commonly seen in these individuals. Cognitive therapies are devised. Paradoxical intoxication is also done for these individuals. Moving on to the sleep hygiene in these individuals is again very important to discuss over here. What are the factors that we're going to consider when you're taking the sleep history, which were basically the timings of the sleep, the environmental factors that can cause the sleep disorders? The environmental factors can be light, noise, room temperature has to be at an optimal level when you're going to sleep. The mattresses that are available for the geriatric age group people, they have their own significances, and they can be the causative factors for the sleep disorders as well in these individuals. Then there can be the health factors that can form the baseline for the sleep hygiene as well, and they can range from the diet of the individual, the exercises if they are devised for that particular individual, what are the particular exercises devised in these particular cases. And then we have substance abuse on the other hand. So when we have a look at all of these causative factors, and when we are negating any factors that are present in the sleep hygiene of that individual that is basically causing these sleep disorders, it's again very important to take the history in detail and even to take a collateral history in detail if it is taken from a primary caregiver, just to know the patient more and just to have the insight about the causative factors. So there are a lot of non-pharmacological managements. On one hand, we have the cognitive therapies. If a resident is not cognitively impaired, identifying the dysfunctional beliefs and attitudes about the sleep and replaces them with the adaptive substitutes over here. So this is the cognitive therapy or the CBT that is devised for these individuals suffering from the sleep disorders. Then it basically helps minimize the anticipatory anxiety and arousal, which is quite commonly seen in these individuals as well. When we move on to the pharmacological treatments over here, on one hand we have the FDA approved drugs, and on the other hand we have the non-FDA approved drugs as well. The FDA approved drugs, it includes the benzodiazepines, the non-benzohypnotics type 1 GABA receptor agents. Then we have the acizopylene, and then we have the Rozirem. These are the drugs that are basically FDA approved on one hand, and the drugs that are non-FDA approved, it includes the herbal therapies that are quite famous these days, and then we have the hormones and the therapeutics. The naturopathics are one of them, and then we have the sedating antidepressants and the OTC antihistamines. So these are the non-FDA approved drugs that can be devised for the sleep disorders in these individuals. So basically in this section, we summarized the sleep disorders, what are the causative factors, how are you going to evaluate these patients, and what are the treatment guidelines that are devised for these individuals who are suffering from the sleep disorders. So that is the end of the section. Thank you for watching sqadia.com.